Hi everyone, my name is Sarah Duke-Mason and I'm the Rural Health Networks Manager for AHI. We're going to kick off today's meeting with a couple of telehealth policy updates and then we'll turn it over to Brian to give our main presentation. I do have a few people online planning to present, so I will just go in order of the names I have written down. If you have given me information and you don't have anything to add now, just let me know and I'll put it in the notes or I can give what you already wrote. So the first I have is Casey DeBellis from DOH. That's what I thought. Here, try this, Casey. I unmuted it again. Did that work?
Afternoon, everyone. Can you hear me now? Okay.
Yes.
Thank you for your help. Hi everyone. My name is Casey DeBellis. I work for the New York State Department of Health. In the Medicaid program, I work on telehealth policy. I only have one update to share today. That is that we are expanding our coverage of remote patient monitoring to include two more CPT codes. Those are 99445 and 99470. They're really companion codes, I'll call them, that will have lower time thresholds to make it a little easier to bill for existing remote patient monitoring services. Those are the remote patient monitoring delivered by clinical staff and the remote patient monitoring for prenatal and postpartum care. So not new services, just an easier way to bill for shorter or more acute episodes of RPM. So please look out for a Medicaid update article that should be in the March issue that'll detail the policy parameters and billing guidance for the new codes. And that's it. Thank you very much.
Thank you, Casey. All right, and then next I have Anna Kane, and I do have the links that I'll share in the notes.
This is Anna. I missed the prompt or the question.
Anna, if you're really hard to hear you.
Can you hear me now better?
Yes.
Awesome. I hopped on right as I heard you introducing me, so I wasn't sure if you asked a question or just said my name.
Nope, I was just asking about your updates that you had sent me on the Part 596 training piece.
Oh, yes. Okay. So the telehealth FAQ document that followed the most recent refresher on Part 596 as they stand currently, that is in the process of being posted to our website, and as many folks as we can reach with an email blast will get that. I can of course send you the link as well, and so that's our next step. As far as that, the reg amendment group is also still ongoing, so no updates formally there.
Perfect. And I'll share the links that you sent me already, and then when that gets updated, if it's any different, yeah, if you send the link along, I'll pass it out. Perfect, thank you. And then I have Kelly Grace from OASAS, and you are on. Let me just request unmute. Oh, went back on mute. Let me try. How's that?
Hi, I said no updates here, so we're good.
Perfect. Thank you. As I make you unmute again.
That's okay.
Thank you. And then lastly is Anthony Jamrosi and Wanda Pamphile. I don't know who wanted to take it from CMS. I know, Anthony, you mentioned giving an update. So I'll unmute you, and Wanda, if you want to chime in, just let me know.
It's basically old news. I mean, like the budget legislation extended the waivers of place of service and geographic, uh, through the end of the year. So this, I don't know if that's, if I could give that 10-second update if you like, but that's what I have.
You're good. Is there
Okay.
anything, I guess, is there anything additional to what Wanda, this might not be helpful because I'm kind of jumping on Anthony here, additional to what Wanda had mentioned in January?
What did
That
you
the
tell
partners
them?
didn't
It
take care of?
was that is I wasn't at the meeting, so I don't
I
know what she
know.
said.
Oh, and
So
is she on?
I don't see her yet,
Okay. Well,
but
we'll leave it at that, and I'll take all your
okay,
edits, and then if she knows of anything else, she can let me know and I can add it to the notes.
okay,
She
all right,
mentioned that
great.
it was you would be fine, so I'm assuming nothing.
Oh, okay, okay.
Perfect. Thank you so much, Anthony. All right, so with all of that, I'm going to turn it over to Brian Westlake, who is the founder of Virtual Mechanical Physical Therapy, PLLC, to give an overview of delivering the right musculoskeletal care in right place at the right time via telephysical therapy. And if you need me, I'm going to mute and hop off video, but if you need me, just call out my name.
Sounds good. Thank you, Sarah. Let me share my screen here. And I'm hoping you all see a slide that says delivering the right musculoskeletal care in the right place at the right time.
Yep.
All righty. Well, thank you. Well, thank you everyone for allowing me to take a bit of your meeting this afternoon. And Sarah, thank you for reaching out and connecting. And Kimberly, thank you for sending the meeting link. Appreciate it and successfully made it in. So just wanted to give you a little bit of my background. I'm a physical therapist by training, just completed actually a 25-year career with the VA hospital system. Worked primarily in the VA Finger Lakes region, and then towards the end of my career, actually went down to the Bronx VA. So I retired as the Associate Medical Center Director for the James J. Peters Bronx VA. And in my 25-year plus career with the VA, I spent a lot of time working in telehealth as a clinician, as a program manager, helping to set up different telehealth entities. When I was in the Finger Lakes, we worked a telehealth scheme from Rochester through Canandaigua, Bath, Wellsville, Elmira, into northern Pennsylvania and Wellsboro and Coudersport. And then when I moved over to the Bronx, which is a level 1B facility, had a lot of specialties within the building, we went northward up into the Hudson Valley and then down into Asheville, North Carolina, where we delivered primary care, mental health care, into Dublin, Georgia, and then several specialties throughout the country. So I really got a good taste for the power of telehealth. And with my background in physical therapy, also kind of got me started in the direction of thinking about how I could deliver telehealth physical therapy to offer musculoskeletal care to areas of New York State that are especially underserved. And so that got me started, and I'll go into the specifics of kind of how that evolved, but I wanted to touch on a few things before I got there. And one of them is the prevalence of musculoskeletal injuries. Many of you may be aware of this data, but low back pain is the leading cause of disability worldwide. And as we know, nearly 20% of our GDP is spent on healthcare, and nearly 4% of that 20% is actually musculoskeletal care. So recognizing the prevalence of this, back pain is the leading cause of disability, and neck pain is usually third or fourth on that list. So definitely a high prevalence of musculoskeletal conditions that patients experience. And then kind of looking at that further, in my VA career, I spent a lot of time with primary care, and came to know that about 1/3 of a primary care physician, NP, or PA's day is spent seeing patients with musculoskeletal injuries, whether that be low back pain, neck pain, extremity pain, or a whole plethora of musculoskeletal injuries. And a lot of times, the treatments that are offered, if X-rays available, they'll shoot an X-ray, prescribe muscle relaxers or pain meds, and perhaps advise on using ice or heat, and sometimes give an exercise sheet or kind of a lead into where they might find a YouTube video that could be helpful. And unfortunately, a lot of times those interventions don't really allow that patient to recover fully. And then that patient ends up kind of coming back for more visits, and it just starts this cycle with them that puts a demand on the clinic and that clinician's time, and kind of doesn't get the patient where they really want to go. The good news is that research and clinical outcomes show that once a patient understands the behavior of their symptoms through position and movement testing, oftentimes they can take control and recover from their injury actually quite rapidly. And for me to make that kind of a statement, I have to take you all back to Auckland, New Zealand in 1956. And a physiotherapist, and in New Zealand they call them physiotherapists, not physical therapists, but physiotherapist named Robin McKenzie and a patient named Mr. Smith. And what ended up happening was it was a clinic day, very busy clinic day. Robin was in the clinic and Mr. Smith walked in, and Mr. Smith had low back pain and pain down his leg and quite a bit of pain. And Robin was busy working in the main clinic area and told Mr. Smith, there's a room over there, go lie down on your stomach and I'll be in a minute. And so Mr. Smith listened to those instructions and went into the room and lied down. And this is actually a picture of how he was lying on that treatment table. When Robin came in, he had forgotten or didn't realize that previous patient in that room was there for a shoulder injury. So they were lying on this table face up, but with the head of the bed up with their for their shoulder treatment. So Robin came in the room now, and in 1956, it was considered dangerous to put anybody in an extended position that had low back pain, especially those with leg pain. And so Robin, very concerned for Mr. Smith, said, "Are you okay?" And Mr. Smith looked up at him and says, "To be honest with you, not only am I okay, I don't have any leg pain right now, and I have very little back pain for the first time in 6 weeks." And so Robin, thinking kind of quickly, said, "Well, okay, well, great." He said, "What I want you to do is I want you to go home and I want you to get in this position every few hours and for the next 2 days and come back to see me." And that's exactly what Mr. Smith did. He came back and told Robin. 2 days later, he was virtually pain-free. And 2 days after that, he actually was pain-free. And that set Robin on a 50-plus year career of figuring out why was this happening and was there something to it. And this is Robin here. That is not Mr. Smith. That is he's teaching a course, and that's one of the course participants. But this was something that he delved into very heavily, to the point that it became a worldwide form of care and gave rise to the McKenzie Institute International and to the form of care that is now known today as mechanical diagnosis and therapy. And one of the things, as Robin went on to discover more and more about these principles of movement and positions and how they impact pain for people with low back pain and neck pain, was he never wanted to be a guru of the method. He wanted the method to speak for itself, and he really wanted to subject this method to research and clinical outcomes. He was very adamant about that. In fact, in naming the method, it's now mechanical diagnosis and therapy. Used to be called the McKenzie method, and he wanted that switch because he did not want it to be known as the McKenzie method. Interesting, the institute, the USA chapter, is actually located in Syracuse, New York. So we have definitely a presence here in our region of the country. So in subjecting his method to research, there's been several studies done on this method, and I pulled out 5 here that I think are kind of seminal over the years. The first one, done in 1997, was a study where they took a clinician trained in mechanical diagnosis and therapy, and they assessed the patient, and then they put these patients through discograms. And what they found is that the mechanical assessment rivaled an MRI in being able to detect a painful disc in the lumbar spine, and in fact, actually proved to be superior. That mechanical assessment proved to be superior in determining whether that disc was painful. It showed up as maybe herniated on an MRI, but wasn't necessarily painful. Well, mechanical assessment correlated well with finding those painful discs. Then in 2004, they did a study looking at, through the assessment, determining what movement would most benefit the patient. And when they matched that movement with the patient and their condition, they found a significant reduction in the need for MRIs and surgeries and injections. And actually had an overall a high percentage of patients that responded quite rapidly, meaning relief within days when they matched that exercise. In 2019, this looked at study, the Michelin Tire Company actually looking at the cost of care when a patient, they're a self-insured company. So when that patient is put through a mechanical form of care versus conventional care, they actually found over 51% cost reduction because of the lowered use of MRIs, injection surgeries, and other downstream care. And then in 2023, they actually showed a significant reduction in the need for lumbar surgeries for those patients who were actually on a list to have surgery. And when they had a mechanical assessment, they were able to take close to 45% of those patients off that surgical list because they had recovered. And in 2020, they did an interesting study about looking at the prevalence of extremity pain of spinal source. So that meaning if you have shoulder pain, elbow pain, wrist or hand, or hip, knee, foot, or ankle pain, how often was it that a patient's, that pain was actually coming from a patient's spine? And they used the mechanical assessment to determine that. And they found that over 43% of patients had extremity pain of spinal source. And looking at in a little more detail, the 322 study subjects, they found that 47% of them had shoulder pain that was coming from the spine, and 44% for the elbow, and 38% for the wrist hand. And the big winner was the hip. 71% of the time, the hip pain was coming from the spine, and the knee pain 25%, and foot ankle 29%. So, this was quite a discovery, and helped us understand as therapists as to sometimes why we may be treating the knee or the elbow and patient's not getting better. Well, we better go back and screen the spine and make sure that we aren't treating the wrong area of the patient. So here's some just the citations for those studies that I mentioned. But Robin also wanted to subject his method to clinical outcomes. And fortunately, a company in Tallahassee, Florida called Integrated Musculoskeletal Care has collected data on over 1 million patient encounters, and also has worked with several self-insured companies looking at claims data. And what they found was that when a patient goes through mechanical care, there's about a 75% reduction in cost of care, and looking at it per member per year perspective. And also they were able to, kind of similar to that study, pull about half the patients off the surgical list for lumbar spine surgery. And interesting, IMC, Integrated Musculoskeletal Care, delivered 81% of that care through telehealth. And what they found was, whether it was an in-person visit or a telehealth visit, the outcomes were very similar. And so, this really helped to gain momentum with this method and its effectiveness, both as an in-person form of care and telehealth. Now, how does this work? I am keeping an eye on the chat. If there's a question that comes in, please feel free to stop me, or we can hold questions to the end. That's up to you all. But how does this work? And I won't go into all the detail, but a kind of a broad stroke overview of how this works in delivering MDT through a telehealth pathway. Starts with a history, just like any clinical exam or encounter does, in terms of, number one, ruling out any red flag conditions, or being able to ask those critical questions that would indicate a red flag or more complex condition that's out of the scope of the physical therapist, and then being able to refer that patient on to the appropriate healthcare professional. So that's the initial part of the assessment. And once those red flags are kind of ruled out, then it goes on to some questions that really help to understand the behavior of the patient's symptoms. And there's really 6 key questions that really help to drive the beginning of this assessment. One is, where's the pain located? If it's neck pain, is it in the neck? Does it go down the arm? If it's low back pain, is it in the low back? Does it go down the arm, or is it just specifically in one joint? How long has the patient had the pain? Did it start yesterday? Is it a week ago? Months ago, or years ago? That helps to understand what state the tissue of the injured area could be in. Are the symptoms constant or intermittent? Are those symptoms, for example, if they have neck pain into the arm, is that arm pain always there, or does it come and go? Does that neck pain, is it always there, or does it come and go? And then, is there an obstruction to movement? Very commonly with somebody with low back pain, if they sit for a long period of time and they go to get up from sitting, it's like they almost have a hard time straightening up. And that's kind of an example of obstruction to movement. It's like that movement is not smooth when they go to get up. And then question 6 is kind of a bonus question, is have they found anything, a position or movement that makes their pain better? And kind of putting the answers to those questions together, then you move into a cause and effect movement analysis, where you're putting the patient through certain movements and understanding their symptom response to those movements, so that you can then key in on which of those movements may be the therapeutic activity that they'll need to do to resolve their condition. So as you get through that assessment with the patient, and again, this is on the screen just like we're doing right now. I'm on the screen like this, and I'm leading the patient through movements and positions and getting the response of how their symptoms are changing. Generally, that kind of funnels down into 4 main categories. There are others, but these are the most common that a patient would kind of be would go into as the assessment is done, both those questions that I mentioned in the cause and effect movement analysis. One thing that shows up very commonly is they have what we term as a derangement, or a rapidly reversible condition. And then thinking about this, it's something in the joint has shifted, whether that's in the spine or in the extremity joints, has shifted into an area where there's a nerve sensitivity, and oftentimes finding a movement helps to shift that structure out of that area and resolves the condition. And the resolution is really within days or just a couple of weeks. It's quite dramatic and rapid. The next is a dysfunction or remodeling of tissue. And this is kind of like that traditional rehab where you think of muscles, tendons, ligaments that have been damaged and they didn't make it all the way through the healing process. And so putting them under a load or stress in a therapeutic way over weeks or months in a specific exercise helps to then get the remaining phases of that healing to occur and allow that patient to recover. A third category is kind of general rehabilitation, where you really need a program of exercises for that patient to engage in to restore their function. And that too is more expected recovery over weeks or months. But certainly those exercises, you can guide them through those exercises via virtual arrangement. And then the last is, put them through a mechanical assessment and determine that I'm not the right person for them and they need to be referred out. And this is where, looking across the Adirondack region, where, there are those medical centers and clinics out there that for further evaluation to go through the differential diagnosis more further, that, if they're going to make that long drive, which generally is to those clinics, then this method helps to determine that it's definitely worth the drive. So general course of care, when I deliver physical therapy, it's a little different. Traditional physical therapy, 2 to 3 times a week for 12 weeks is general course of care. I'm looking at, can you give me 3 to 5 visits over 1 to 2 weeks, and 3 things are going to be happening. Either you're going to be better, you're going to be on the way to being better, or I'm going to be able to determine what I have to offer isn't what you need, but through my assessment, I'm going to be able to give you an indication that where to go next for care, and whether that's moving on to seeing orthopedists or more advanced imaging, or perhaps an injection or something of that sort. But I'm going to be able to help and work with your healthcare team to help you get to where you need to go. But I will say about 70% of the time, patients are either better on their way to being better. It's far less frequent that they need to be referred on to another form of care. So as I thought about my experience in the VA, the prevalence of musculoskeletal care, I fortunately was able to get trained in the MDT method very early on in my career. I graduated from SUNY Upstate in Syracuse, and actually the method was taught in our curriculum, and I went on to take additional continuing ed course. Thinking about the research, the clinical outcomes, and I said there is a spot here in telehealth for MDT, and in 2019, separate from my work at the VA, I created virtual mechanical physical therapy, and I went through the process to get my PLLC, and I was still working full time at the VA and doing this on the side. And so I started with the secure telehealth platform. Some of you may be familiar with VC. I originally started with them. I've since moved on to Sesame Care, and The difference there was VC had a monthly fee and Sesame is a pay-as-you-go model, and that worked better for me as the stage of growth that I'm in. Now, New York State is a direct access state for physical therapy. Most states, in fact, I think all states are, but New York State's stipulation is you can see a patient for 10 visits or 30 days as in a direct access, so you don't need a referral from a physician. I do see patients with referrals from physicians, but I have that option that patients can come see me directly. And I started seeing patients across New York State in a cash pay arrangement. And so that really was kind of a very simple transaction that worked for me, again, trying to work full time and develop this. But now that I'm retired, I have pivoted to this full time. I'm working on developing other options of payment, and some of those have come into fruition. My cash pay is $100 per visit, but I offer a sliding scale. I don't want payment to be a barrier to care. People will often use their health savings accounts if they have a high deductible health plan. Their card works in the credit card transactor in the Sesame and VC platforms. It was mentioned earlier by someone about the Medicare. The telehealth fee schedule has been extended and through, it looks like, December 31st of 2027. So I am a Medicare provider, and I do deliver and work through payment through Medicare. I've worked with motor vehicle no fault insurance transactions. I set up an arrangement with a farm, and basically it's a large dairy farm. And what the farmer wanted to do was to have an option for his employees, not a workers' comp situation, because workers' comp does not utilize telehealth, but as a way that if one of their workers starts to feel maybe there's getting a little back discomfort or neck or so forth, and that patient will reach out to me. We'll have visits, and then I will bill that farm, not delving into who I treated, just that services were delivered. And that actually has been going on for a few months now, and it's working out well. Medicaid is a challenge, and I think it was Casey DeBellis. You had mentioned that you were from the Medicaid arm in New York State. As I understand it, for telehealth fee schedule, it's 21 or more minutes in a 7-day time frame. The fee to be collected would be $25.74. So, that's a little difficult to keep, all engines moving at that reimbursement rate. But I would not take that off the table. I'm a Medicaid provider. I've signed up through Medicaid, completed that process, and so, but so that is an option. Other things that I'm exploring are the federally qualified health clinics. The PPS rates for Medicaid and Medicare. I'm in discussion with a couple of FQHCs about, is there a revenue sharing that we could work with, where if the patient comes into the clinic and has an MSK condition, that the provider sees them initially and then they beam me in to help manage that patient's condition. And instead of that patient maybe coming to the clinic one time, they come 3 to 5 times to see me. And is there a revenue sharing opportunity that would be kind of a win-win, where their revenue, they could generate more revenue, and the patient would get care that would help, be able to resolve the condition at the location of that FQHC. So if anybody on this call has, any opinion or thoughts on that, please let me know, because it's something I'm exploring, and it's starting to get some traction, and I'm curious as to others' thoughts. From a private insurance perspective, there's a first dollar coverage in a high deductible health plan, where health plans will offer that telehealth piece, and I'm probably preaching to the choir on this, but I'm in discussions and trying to figure out, would they be willing to do 3 to 5 visits of tele-PT for like the care that I delivered, and make that part of that first dollar coverage, so it wouldn't apply to the patient's deductible, or that they would be covered by their premium. And then, of course, the traditional fee for service. I am working on some contracts in that realm. So payment options, I'm trying to widen the breadth there. So how am I able to sustain this? Number one is a variety of payment options. I've learned that cash pay is difficult for people. And so I am trying to make it more of a rounded payer sources. Patient experience. Patients are very surprised. They're skeptical in the beginning. It's like, I have low back pain. I've had it for a while. You mean to tell me you can put me on screen and you can resolve my condition? And I walk them through the process, and they experience the process, and it thrills me when they're pleasantly surprised, and that never gets old. It's like a good golf shot. The other thing is I don't have a large gym. It's sitting here in an office in my house that has a computer in front of me and some screens, and they have all the equipment at their home. So we're using whatever we can find at their home as the equipment to resolve their condition. I'm very, very particular about the telehealth platforms I use because I want them to be simple and easy for people to use. VC and Sesame have proven to fit that bill. I don't pursue new tech shiny objects because I really have found that less is more. And that the simpler I can keep it, the more attractive it is for people and the more practical it is for them to utilize, whether that's at home, at work, or wherever is most convenient for them. Challenges, convincing patients that, physical therapy can be delivered effectively through telehealth. It's been, it's a challenge, although I will say less so than when I first started, because a lot of patients I get through word of mouth, and that patient that I saw kind of has already explained to the new patient about, how this all works. Trying to grow a practice working full time, I learned the hard way, is very challenging, but fortunately that's no longer an issue as I am now pivoted in this direction full time. Get from that cash pay model to those other payment options. It's been an adjustment, but I'm working through it. There's been some connectivity issues, but honestly, that hasn't been a big issue, a big barrier. One of the few of the ways that I've worked through overcoming that, and I know that I'm preaching to the choir on this one, but just, using those community centers, libraries, firehouses, churches, municipal facilities, and whatever other option is available in the community that may have the connectivity that the patient doesn't have in their home, but it's certainly a shorter drive to drive there than it is an hour and a half elsewhere. Successes. I'm thrilled when people are pleasantly surprised with the outcomes. I've had a couple of farmers who've lived with pain for many years, and a few simple exercises, and for one of them they became pain-free, and the other one still has intermittent pain but manages it through his exercises, and just didn't think it was possible. Reaching patients who hadn't received, who otherwise wouldn't have engaged in care because they couldn't, whether it was a travel barrier or a time barrier, they just couldn't make it out. I'll see patients at 8 o'clock at night if that's their only option. We'll get on a screen and they're at home, I'm at home, or sometimes they're at work and I'm at home, and we can help them. Trying to grow that patient volume year over year, which has happened. It's been a slow grow, and so but still, learning from every patient interaction to help generate the next one, and attracting patients from across New York State. I've seen a bond trader in Manhattan, to a hairdresser in Baldwinsville, to a small business owner in Pittsburgh, just south of Rochester, to farmers in all the rural, many of the rural counties in New York State. It's been a thrill to be able to cover that kind of ground. Now, how could I be of help to the AHI Learning Collaborative? The one thing is, and really was the impetus to start this from the beginning, is how, reaching underserved areas of the Adirondack region. When I was in the VA, I really saw how, for example, I'll just use the example of Coudersport, Pennsylvania. If you know that region of Pennsylvania, very, very small town, not a lot of clinical activity going on there. And with our little clinic, we were able to beam in some great care into that region, and that helped me. That made me appreciate, what telehealth could be for those types of communities. So if I can deliver high quality, low cost musculoskeletal care to those underserved areas in the Adirondack region, that is my target audience. One of the things that I also learned in the VA is the importance of being able to start that clinical assessment in a telehealth fashion, so that if that patient does have to come to a brick and mortar, they're coming through the door that they truly need to be coming through. Some of you are probably aware in the VA system, they have what are called clinical resource hubs. Every VISN has one. And that was one of the things that I was very much advocating for, was that those clinical resource hubs would be that entry point and to the healthcare system. And then, as I mentioned earlier, a place like the Bronx that has like an eye clinic. If the patient had something in their eye that needed to be addressed, that it couldn't be addressed over telehealth, but we could get them into our brick and mortar and know that, the best door for them to come through initially was through the eye clinic door, as opposed to showing up in primary care, being evaluated, and then, if they had an opening in the eye clinic, moving over to the eye clinic. So it was very, very helpful there. So I'm hoping that I can help patients, especially in underserved areas, get through the right door of clinics, and making that long drive that usually is, if needed. And as I mentioned, oftentimes it's not, because you can solve a lot through telehealth, and just, getting patients to the right musculoskeletal care in the right place at the right time. It really is what I'm passionate about at this point in my career, and look forward to helping many more patients in that regard. That's the information that I had for today. I put my contact information up there. I'm very interested in hearing from all of you, how I could reach areas and improve my process. I know I haven't got it all figured out, and I would never claim that I have, but how can I help this group and whoever else you think would be beneficial? So, Sarah, that's what I had, but I want to open it up for questions here.
Thank you, Brian. We did get one question. Have you offered this service for patients in nursing homes?
So I haven't, but I certainly would be willing to explore that. I don't, I'm open to anything, to be as creative as possible. I definitely, we have to be creative in the situations that we find ourselves in delivering healthcare. So I haven't yet, but certainly would like, would be interested, definitely.
Another is, have you struggled to find access, or for patients, I guess it's more for patients, but have you struggled with patients finding access to the tools or the equipment that they need?
No, in fact, in terms of doing the exercises, so I'll give you a great example. So a lot of times with low back pain, one of the big things is postural correction. So I'll say, okay, do you have a chair in your house that has a hard back that kind of sits up like this? And can you go in the bathroom and get a bath towel? And then I have them roll up the bath towel, and I say, okay, sit in that chair, hits tight to the back of the chair, and let that towel fall into the small of your back. And that's part of that position assessment. And then understand how their positions change. So their symptoms change. So that's one part of the assessment. The other part is I just have them on the floor, and they're doing an exercise on the floor. Or another commonly used item in the home is the kitchen sink. Standing with their back against that sink and leaning backwards. And so in fact, no, I mean, people at home, they have the tools. I had one farmer, he uses the tailgate of his pickup truck. He, when he's having an issue, he puts the tailgate down, turns around, leans against it, and bends backwards. And we've had visits with him in the field, and it, to show him the practicality of using, what he has right there on his farm to resolve his condition.
Love that. That's awesome. I don't have any questions yet. I'm going to give it a minute. I think you have to come up with the practicality, because if you have patients who think that the equipment is required or certain pieces are required, you're going to get pushback. So
Yep.
to know that it's as simple as a chair in your home, which most people would have, again, the tailgate to the truck, you make it work.
Yeah, absolutely. Yeah. No, honestly, equipment has not been a barrier. It's there, and the way the method works is, understanding. I'll give you just one example that's a little bit more detail into the MBT method. A lot of patients have back pain, and maybe some of you on the call have experienced back pain that travels down into your leg. Okay. When there's a phenomenon called centralization. And that is that when certain positions or movements will have that pain move out of the leg. So let's say that pain is down to your foot. A certain position now the pain isn't in the foot, it's up at the knee. And I do more of that, it goes up into the thigh. And now as I do more of that, it's really just central in my back. And now that back pain is getting better. So when I see that in the patient, and that's a very common thing to see, that tells me that movement is what that patient needs at that time. On the other hand, if they do the movement, and maybe it was in the buttock, and now doing the movement pushes it to the knee, to the calf, to the foot, That's not the movement they need. That's called peripheralization. And that's telling me that the nerve is being pinched a little bit more. This is the model of the spine. And I don't know if you can see this, but when you have the vertebrae and then you have the disc in the middle, and when you bend forward, a lot of times the discs can bulge, and when they do, they hit the nerve. And I do a lot of training of people to do just the opposite of bending forward. That's bending backward, which pushes the contents of that disc forward off the nerve, and that's why that phenomenon of that pressure coming off the nerve and that pain receding up the leg and into the back. It's because you're relieving the tension on the nerve, and when it goes in the opposite direction, you're putting tension on that nerve. So those are very significant signs to understand if you've hit on the right exercise.
Gotcha. Eileen said there are so many people with back pain. I can believe that this would help many of them.
Yeah, absolutely, yeah. And unfortunately, a lot of people with back pain who they have control, they just need to be taught. And once they're taught, they then gain control. And a lot of times I wish I would have known about this 10 years ago, because I've been battling this 10 years. My record honestly is 30 years. I had a patient, and this doesn't happen often, but a patient did have back pain for 30 years, and we were able to resolve it in a week. I'm going to say it doesn't happen like that often, but it made me appreciate that. Wow, this, you can change somebody even though it's been long standing.
Yeah, that's incredible. Question was, do primary care providers need to make the referral?
So in New York State, we are a direct access state, so that I can see a patient. Like if you knew of a patient and that needed help, they could contact me directly. I can see them for 10 visits or 30 days, whichever comes first. And that's generally enough time, because if I haven't got it figured out by then they probably need to move on to another form of care. But no, they can refer to me. They themselves can self-refer to me directly. All right. I have to do a little disclaimer that, you're being referred directly. So, your insurance may not pay for it, but I've not run into a big issue of them running and, having a pay issue because of this, because used to be only a few states had direct access. But now all states do. So it's pretty common.
And Jenny, they did mention this, but do you take workers' comp?
Well, workers' comp does not allow for telehealth. If somebody understands that differently, please let me know. But from the research that I've done, they do not allow for telehealth to be delivered for physical therapy for workers' comp. And if I'm wrong about that, I've dug into it, and that's where it's kind of led me.
I agree. We do need to advocate for
I
change for
agree.
sure.
Yeah. And I mean, great example is the farming community, because, they do have some people that are, work injury is on the job. And I have to tell them that for that case, I can't treat the patient.
Yeah. Any other questions? And for those of you who might not want to throw a question out there now, but maybe think of one after, or just want to have a separate conversation, I'll include Brian's information in the notes, including his email and cell phone number that he has listed here.
Yes, please do. Like I said, I'm open to being creative. I'm thinking of these rural health clinics and how access into each and every appointment that clinician puts on their schedule is like gold, and how it just never seems to be enough. And as I mentioned earlier, that 1/3 of those appointments more than likely are for musculoskeletal conditions. So is there a way for me to relieve some of that in these underserved areas of the Adirondack region, where now that primary care physician or nurse practitioner or physician assistant can be helping patients with more like diabetes management, hypertension, heart failure, COPD. If you know of rural health clinics out there that are struggling with access, I really would love to be able to help those facilities to be able to open up some slots.
Well, the one thing with rural is that the relationships make the biggest impact. And I feel like if you have good relationships or can find your way into those, that's where you find your footing, and
Yep.
rural helps rural. So I think you'll find your right way, and then you'll be able to expand who you need to expand to. So I appreciate it.
Yeah.
I don't see any other questions coming in for now. So what I'll do is, like I said, I'll put your information in the chat, and then we'll have that for any questions to come through. And again, if anybody sends anything to the telehealth inbox, Bob, myself, we'll happily pass it along.
Sounds
So
good.
thank you so much, Brian.
Thank you. Appreciate the opportunity.
Thank you. And then Eileen said, I would think this would appeal to the state for drug-free back pain option.
Yes, I would agree. I think, because that's the other thing as I see is when they don't get, treatment for their back pain or their neck pain, then they turn to medication. And sometimes that's heavy medication. And I saw that way too many times in the VA system and can see the impact of, being able to give a musculoskeletal care option instead of heavy pain medications, how impactful that can be. So yeah, I agree.
Yeah, this was great. Thank you so much.
You got it. Thank you.
The only other thing I wanted to share with everyone today, and I'm hoping my computer lets me, is the 2026 Summit Save the Date. So for those of you who are familiar with the North Country Leadership Summit, the dates for this year are September 30th and October 1st. It'll take place again in Lake Placid at the Lake Placid Conference Center. And this year's theme is Partners in Progress, Transforming Rural Healthcare Together. More information to come. This is just simply the save the date and a brief website hold. And then as we get the forms filled out, so that's the call for presenters, our sponsorship forms, our Telehealth Innovator Award nomination forms. Once all of that is completed, another announcement will go out, and then we'll get that out so people can start submitting forms. And we are doing a couple different additions to the summit this year. We want to see more student involvement just because student is our future, and we really would like to see more involvement in that side of things as well as posters. So I don't want to give a ton of detail because I don't necessarily have a ton of detail on the poster component yet. But essentially we don't want to leave presentations on the table. And so we would like to be able to include poster options as well. So more to come. You'll see all that in the forms, but if you have any questions on presenting, attending, sponsorship, any of that, please let me know. I'll put the AHI Summit inbox in the chat. Sean, I see your thing. I will. Brian, thank you, Brian. Perfect. I'll also put the Summit inbox in the chat for Summit, and then you'll also have it in the notes. Is there anything anyone else wanted to add to today's call? If not, I can give you back some time in your day. But I'm glad to open up the floor to anybody who may want to add something in. No? All right, quiet group today. I will put everything in the notes, get those out to you guys as soon as possible, and then Kimberly and I will work on the recording. Hopefully it's set this time, and we'll get that uploaded and out to you guys. So thank you guys for joining, and you'll have all the information you need. Have a good day.